I'm Deanne Lacaille, a rheumatologist at the University of British Columbia, and I'm going to discuss the disease activity measures that are used to assess disease activity when seeing patients with rheumatoid arthritis in follow-up. Standards of care for rheumatoid arthritis currently emphasize the need for early and aggressive treatment with disease-modifying agents, or DMARDs. The goal of treatment is to eradicate inflammation because that's what's needed to prevent damage to the joints and to prevent the joint deformities, the loss of physical function, the work loss, and the premature mortality that comes along with severe disease. To achieve this, it's recommended to use a treat-to-target approach, where the treatment is modified by either increasing the dose or adding or changing a medication until the target is reached. And our target is little to no inflammation. We're now aiming for remission with rheumatoid arthritis. And if we can't achieve remission, then low disease activity is also acceptable. We now have the medications to be able to achieve this in most patients if treatment is started early. This begs the question, how does one know if the target has been achieved? And this is where the disease activity tools, such as the one included in the toolkit, are useful for assessing disease activity during follow-up visits. So let me explain how to use the disease activity tool. We recommend to use the disease activity index because it's simple and rapid to use during clinic. There's two versions of it, the simple and the clinical disease activity index, and essentially the only difference between the two is whether or not we include the CRP, and it depends on if it's available. If the CRP result is available, it's preferable to use the version of the disease activity index that includes the CRP. And the reason for that is that we like to see a normal CRP because it indicates that there is no systemic inflammation. To calculate the disease activity index, the first thing that we need is to have a tender joint count and a swollen joint count, which is when we count the number of tender joints and the number of swollen joints. An easy way to do this is to mark it on this homunculus, which is a picture of the body with all the joints as we examine the patient, and then add them up to have the number of tender and the number of swollen joints. Then we need a measure of a physician assessment of global disease activity, which is asking yourself to rate how active do you feel the patient's rheumatoid arthritis is based on your history and your physical exam using a 0 to 10 scale. Then we need the patient assessment of global disease activity, and this you can obtain by asking the patient, considering all the ways your arthritis has affected you, how do you feel your arthritis is today? And you ask them to rate this on a scale from 0 to 10, from very well to very poor. And now to assess the disease activity, we're going to calculate either the SDI, which stands for Simplified Disease Activity Index, or the CDI, which stands for Clinical Disease Activity Index. And this is the simple sum of the items that we just mentioned. And the SDI includes the CRP, whereas the CDI does not. To calculate the disease activity index, we add up the values of the number of swollen and tender joints, and it's important to not include the feet in the joint counts for the disease activity index, as well as the patient and the physician global assessments of disease activity, and the CRP if one is calculating the simple disease activity index, and it's left out if one is calculating the clinical disease activity index. I know it's a little paradoxical. The CRP is actually in the simple disease activity index. Cutoffs have been established for the SDI and the CDI to classify whether patients are in remission, low, moderate, or high disease activity, depending on the value of the SDI or the CDI as shown in this table. And finally, this is a flow chart based on the results of the disease activity index. And if the disease activity index score indicates remission, as indicated by the green, it means that our main target has been reached, and we don't need to change the DMARDs. Now, if someone has been in a sustained remission for at least 6 months, and we can attempt to try to reduce the DMARDs and try to find if we can maintain a remission on a lesser amount of medications. But it's very important to only do this if it's been a sustained remission and to do that very gradually. In the yellow is the low disease activity. And there it depends on whether or not there is still some room to play with the DMARDs. If the DMARDs have not yet been optimized, for example, if someone is on 15 milligrams of methotrexate and is tolerating this very well, there's a lot of options left. We can either increase the dose of methotrexate, we can add another DMARD like hydroxychloroquine, and therefore the recommended course of action in that case is to optimize the DMARD therapy in order to try to achieve the desired remission. However, there might be some circumstances where a low disease activity state is acceptable. In a patient who's had long-standing disease, in a patient who's already on maximum DMARD therapy, and where the additional risk of additional DMARDs outweighs the benefit. And in those cases, no change in DMARD therapy may be the best option. And finally, if someone has moderate or high disease activity, as indicated by the red here, then it means that the target has not been reached. We definitely need to do something here and modify DMARD therapy. If they're on maximum traditional DMARD therapy, this is when we would go to a biologic agent. So hopefully, this disease activity tool is useful in clinical practice to assess disease activity state and to guide further treatment.